Good afternoon, everyone, and welcome. My name is Megan Macklin. I serve as a program manager in the UC Davis Office of Diversity, Equity, and Inclusion, where I manage the Campus Community Book Project. Thanks so much, everyone, for joining us this afternoon. To begin, we're going to go over a couple of housekeeping items for our virtual event. I know some of our folks here today have been following along with our book project events. I want to note that we've instituted a number of new security measures, so we'll hope you'll bear with us with those. And we hope that these efforts will balance the need to maintain event security while also staying true to the intent of today's presentation as an opportunity for dialogue, collective learning, and community building. Today's event features live captioning from Otter Live Notes. To access a live transcription, you can click on the red live icon on the top left of your Zoom screen. You also can access the live stream by navigating to the link that we'll put into chat. Today's event is being recorded and the recording will be made available on the Book Project website. During the presentation, all participants will be muted in order to limit disruptions, but we do encourage you to turn on your video if you're comfortable or in a position to do so. It's great, especially for our presenter, to see faces. We've disabled the option for participants to rename themselves, but if you wish to rename yourself, please feel free to send a chat to me, Megan Macklin, or to my colleague, Sunny Desange. You're invited to ask questions in the chat during the presentation and the question and answer portion. Please chat your questions to me and I'll ask them to our presenter during the Q&A. I'll also post the questions into chat for everyone to see as they're being asked. And during the question and answer, you can raise your hand using the raise hand feature, which you can find at the bottom of the participant menu. I'll then call on you and invite you to unmute yourself to ask your question. The UC Davis Campus Community Book Project promotes dialogue and builds community by encouraging diverse members of the campus and surrounding community to read the same book and attend related events. The Book Project, a signature initiative out of the Office of Diversity, Equity, and Inclusion since 2002, advances the mission to improve both the campus climate and community relations, to foster diversity, and to promote equity and inclusiveness. Currently in its 19th year, the Campus Community Book Project in 2020-2021 focuses on the theme of mental health and features graphic memoir Marbles, Mania, Depression, Michelangelo, and Me by Ellen Forney. The theme and selection are supported by a year-long program of lectures, workshops, book discussions, film screenings, exhibits, performances, and more, which this year will take place virtually. Our program culminates when author Ellen Forney joins us on Monday, March 1st at 4 p.m. for a virtual lecture and live Q&A. With support from the UC Davis Office of the Vice Chancellor for Diversity, Equity, and Inclusion, the Robert and Margaret Mondavi Center for the Performing Arts and Downey brand, we are really pleased this year to offer this event free of charge. For more information about Ellen Forney's talk and about the Book Project program, visit our website where you can find up-to-date event information, registration, and other resources. We also welcome your involvement, that includes students, staff, faculty, and community members, in selecting the Book Project featured title and in planning our annual program. If you are interested in getting involved with the Book Project, please send us an email or refer to the Book Project website for more information. And now it is my pleasure to introduce today's speaker, Dr. Hendry, who will present on addressing bias and racism in mental health and mental health treatment. Dr. Tan is the Associate Vice Chancellor for Health, Equity, Diversity, and Inclusion at UC Davis. He also is the founding medical director of the Transcultural Wellness Center of Asian Pacific Community Counseling, a community clinic that specializes in serving the mental health needs of Sacramento's diverse Asian and Pacific Islander communities. As Professor of Psychiatry and Behavioral Sciences, Dr. Tan has led the department's courses and initiatives for medical student education. Under his watch, the psychiatry clerkship ranked in the top 20% in a nationwide assessment conducted by the Association of American Medical Colleges. He has received the UC Davis Chancellor's Achievement Award for Diversity and Community, the Dean's Award for Excellence in Community and Engagement, and the Dean's Inspiration Faculty Educator Award for his work with students, communities, ethnic minorities, and cultural competence. He also recently received the National Alliance on Mental Illness's Exemplary Psychiatrist Award. Dr. Tan presents nationally on the topics of cultural competence, education, and system change. Originally from Vietnam, Dr. Tan immigrated to the United States with his family as a refugee. Growing up with limited access to healthcare, he is well aware of the impact of access barriers on health and wellness. Addressing these issues of health equity has been central to him. His other areas of interest include diversity and inclusion, professionalism, cultural psychiatry, humanism and medicine, wellness, medical student education, and faculty development. Dr. Tan, take it away.
Thank you so much, Megan, for that very flattering introduction. I'm going to go ahead and try to share my screen here. And Megan, is my screen shared all right?
Looks great.
Okay, great. Thank you. So thank you, everybody, for joining us today as I share with you some thoughts and reflections I have developed over the years around bias and racism in mental health and in mental health treatment. The first part of my presentation is going to be looking at some of the biases and racism and the underlying causes for these kinds of racist and biased outcomes for our communities of color. And then I'll go into thoughts and strategies of what we can do to address them and improve the care of diverse communities. So I want to start by quoting, let's see if I can do this, quoting Dr. Martin Luther King. As you know, we celebrated his birthday just a couple days ago. He said that all forms of inequality, injustice in healthcare is the most shocking and inhumane. Because healthcare is at the basis of what we are as a society, that we need people to be healthy, to thrive physically, emotionally, mentally, in order to have a community that's able to move forward in time and space. And in particular, people of color experience a disproportionate amount of mental health distress. Here's a Surgeon General's comments on this. Members of ethnic and racial minority groups in the US face social and economic environmental stressors, inequalities that include exposure to racism, discrimination, violence, and poverty, all of which takes its toll on a person's mental health. And so, for example, Black people and Hispanic people are less likely to report a psychiatric disorder compared to white counterparts. But when they become ill, they tend to have more persistent disorders. Why would that be the case, that if you become ill, your disorders are more persistent? Black, Hispanic, Asian American, American Indian, Native Hawaiian people have higher rates of post-traumatic stress disorder than white people. And this isn't accounted for entirely by socioeconomic status or a history of psychiatric disorder. We know from other studies that that suggest that people of color are at greater risk, more exposed to violence, which is one of the ways in which people develop post-traumatic stress disorder. And perceived discrimination contributes to mental health disorders amongst racial ethnic groups such as Asian Americans and African Americans. And you see also in the era of COVID, we've seen the rise of anxiety and stress and a deterioration of mental health amongst Asian Americans and African Americans in particular, because of xenophobia and because of the racial injustices experienced by Black communities. And compared to whites, African Americans are more frequently diagnosed with schizophrenia, which is a low prevalence but serious condition. And we've also seen this in other kinds of disorders where we've studies have shown mental health providers a case with a person with mental health distress. And the only difference in the cases are their ethnicity. And mental health providers are more likely to diagnose Black people with stigmatizing mental health disorders than with white people. And so there's bias that exists in here that contribute to these mental health disparities. I also wanted to make note as well of the disparities experienced by LGBT people. So if you look at polls that ascertain people's consideration of suicide, which is one of the most distressing, concerning signs of mental health suffering. In a recent survey, heterosexual people, 2.3% of people have considered attempting suicide. Almost twice that number for people who are gay and lesbian. Almost triple that number for people who are bisexual, and more than 10 times for people who identify as transgender. the stress associated with the stigma, with the isolation, and with the discrimination of being LGBT translates into these incredible, this incredible burden of stress that our communities experience. And you'd think that with this kind of psychological distress that utilization of mental health services would be pretty high, but actually the opposite is the case. So if you look at Black community members, Asian, Hispanic, Latino community members, you see that the use of mental health services, the use of prescription medications, outpatient services, and inpatient services are less than average and then by white community members. Now, part of this can be explained by preferences at the community level, but much of this is actually explained by barriers, by stigma, and by discrimination. If you look more closely at the statistics, you see that BIPOC people, or Black, Indigenous people of color, are 25 to 50% less likely to initiate mental health treatment. And this is in the face of, we know through other studies that when a person gets adequate treatment, appropriate treatment for their mental health condition, 70 to 90% of people show significant improvement. Those are actually quite staggering benefits that aren't a par with many other medical conditions. And yet 25 to 50% of people who are BIPOC, they're less likely to initiate mental health treatment. They're more likely to have shorter psychiatric visits. This is especially the case I've found with people who need to use interpreters to communicate, that somehow, even though having another person in the room that contributes to the discussion should actually lengthen the time, we've actually found in the study, some of the studies have shown this, that actually when there's an interpreter in the room, the time it takes to do a psychiatric intake is shorter compared to English-speaking people. Why might that be the case? It seems physically impossible that another person in the room that provides interpretation can shorten. But part of the issues are that people with limited English proficiency have a harder time advocating for their needs and advocating for their perspectives. And so their appointments can be shortened as a result. 40 to 60% of BIPOC people, they're 40 to 60% less likely to fill prescriptions and 40 to 80% more likely to end treatment prematurely. And these things, these kinds of interventions are associated with greater treatment relationship and adherence to treatment. But we also have to acknowledge, in addition to these factors, that there's a legacy that people, many people in communities of color are dealing with, and we in mental health have to also acknowledge. So, you know, there have been medical experimentation done on enslaved people. You know, one of the forefathers of OBGYN did experiments on African women who were enslaved, sometimes with minimal use of pain medications. In the psychological and psychiatry realm, psychiatrists diagnosed African people who tried to escape slavery with drapetomania, basically this pathological desire to get to freedom and leave behind the shackles of slavery. That was a clinical condition. That was a clinical condition. That's the legacy of my predecessors and the legacy as a mental health provider that I have to acknowledge, and as part of the history of my profession. And then there was the Flexner Report. The Flexner Report was basically an analysis of all the medical schools in the United States. And in the Flexner Report, they really wanted to focus on quality improvement at the medical schools. But as a result of the Flexner Report, the majority of historically Black medical schools were closed. to this day, we have not been able to move the needle in terms of recruiting and graduating Black men medical providers. And the legacy started with this report that closed a number of medical schools and the majority of Black focused medical schools. We also have to acknowledge that homosexuality and gender identity disorder were considered DSM psychiatric conditions. And it was only until recently that gender identity disorder was stricken from our diagnostic categories. Homosexuality was stricken from it as a pathologic disorder in the 1970s, but it took until the recent years in the early 2000s that we eliminated gender identity disorder. And in mental health, there were those of us who also did conversion therapy to change gay, lesbian people with the idea that that this was a pathological state that could be cured through specific forms of psychotherapy. Well, we now know that people who've undergone conversion therapy experience quite significant mental health distress as a result. And so this is the legacy that we have. And so as you know, I open my shingle for people of color, for LGBT people to come in to my clinic. And if I'm wondering why they're not coming in, well, this is some of the reasons why. This is the legacy. It's really important for us in the healthcare professions and in the mental health professions as well to acknowledge our role in the discriminatory practices that have led to the oppression of people. Not for us to be paralyzed by the guilt of it, but for us to acknowledge our role in it and to be inspired to do better and to not make the mistakes of the past. One of the most important things about understanding our history is so that we don't make mistakes of the past again. We learn from it, and no one else needs to suffer from it. I want to talk about the social determinants of health. You know, when I went to medical school, I thought that I trained to provide the best quality care possible. And I recognized through my work on disparities that if people don't have equitable access to care, that their health is going to be compromised. But in recent studies, we are seeing that access to care and quality of care makes up an estimated 20% of an overall person's health. And it's not to say that the work that you or I or others in the health professions do isn't important. That 20% can mean the difference between life and death for some people. But we have to take that into context. The context being that education, employment, income, community safety, access to family and community supports, these things make up 40% of a person's health. And so really for us to, as health professionals, as people who are affiliated with a health system, for us to really realize our mission to improve the health of people, we have to think beyond the walls of our clinic. We have to think beyond the 20% to the rest of what we can influence. And that is education, employment, poverty, community safety, income, housing. These are things that are important that we can, we have a role in. But it's also important, you know, I've heard a lot of talk about, well, you know, with these disparities, is it really racism or is it poverty? If we just look at socioeconomics, doesn't that explain everything? Well, first of all, it doesn't actually explain everything because we've seen that, for example, Black professionals who are in the higher socioeconomic strata still experience worse health outcomes than people of similar socioeconomic status. But what we also have to look at is, why is it the case that there's a disproportionate number of people of color who suffer from poverty? And the reason why is that there's structural discrimination, sexism, racism, ableism, classism, that contribute to policies and practices that are also inequitable, that then contribute to poverty, to environmental dangers, to neighborhood violence, and all the things that contribute to wellness. So it's not an either or, it's a what comes first. And structural racism and discrimination, we can see is at the roots. And I'm going to give you an example. So the redlining of Sacramento. Okay, so I'm going to go through a timeline with you. So in the 1920s, there were race covenants on deed restrictions in Land Park and Curtis Park, neighborhoods, and East Sacramento, neighborhoods that are now having high property value. But back in the 1920s, you actually could not buy a house if you were an immigrant or a mixed race couple or a Black person, because there were these deed restrictions. And then in the 1930s, with the advent of the New Deal, the government, the federal government sponsored a corporation called the Homeowner Loan Corporation to look at and facilitate the mortgage lending of people in America, to sort of stimulate home ownership. But what the Homeowners Loan Corporation did was they analyzed neighborhoods and came to the conclusion that there were some neighborhoods that had quote, large amounts of subversive racial elements that put mortgages at risk. And these neighborhoods were predominantly Black and immigrant neighborhoods. And so what happened was that they instituted, through these redlining policies, programs and policies that prevented people from certain neighborhoods that were predominantly Black and immigrant from securing loans. And so the West End neighborhood of Sacramento was given a D or a red score, whereas other communities were given priority for home loans. And what happened was that this led to Black and immigrant people to default to not be able to secure loans, and to then stay in the rental market, to then migrate to other poorer income communities as crime and violence increased in these areas that were redlined. It wasn't until the 1960s that the Fair Housing Act recognized that the practice of redlining was discriminatory and outlawed it. But by that time, the damage was too difficult to undo. And I'm going to show you the consequence of that later. In the 1990s, we had what some would call the reverse redlining, where there was this explosion of subprime loans, and subprime loans being loans that had that were risky to for the homeowners to have should they default on it. And we, in retrospective analyses, we found that subprime loans were 5 times more likely to be given in Black neighborhoods than in white neighborhoods. And when the bottom fell out of the mortgage housing loan market, it led to a disproportionate, staggering loss in Black wealth. Well, what does all this mean? Well, if you look at the wealth accumulation of families, this is 2011, it's actually worse now. You find that Latino and Black families have about $10,000 of assets in their family, compared to white families that have over $100,000 in assets. And if you look carefully at the assets, a lot of this is home ownership, which is one of the most lucrative vehicles for wealth building, aside from investment in the stock market, those two being fairly equivalent. But these policies implemented in the 1920s, reinforced nationally in the 1930s, led to generational poverty. And this poverty then impacts a person's ability to get an education, get a job, have financial stability and insurance, all the things that buffer against poor health. To the degree that if you look at a resident in Oak Park, area code 95817, and compare that to a resident in Davis, 95616, a distance of 20 miles translates to a lifespan expectancy difference of 10 years. 20 miles, 10 years. Poverty. Poverty caused by discriminatory practices. So I think some of you who loved music in the 80s, 90s, and even in the early 2000s know this illustrious person, Prince. And he said this as a lyric in an album, Old School Company. Everybody talking about hard times, like it just started yesterday. People I know, they've been struggling. At least it seems that way. Fat cats on Wall Street, they got a bailout. Well, somebody else got to wait. 700 billion. By my old neighborhood, ain't nothing changed but the date. He so astutely pointed out these kinds of practices that actually make the wealthy wealthier and the poor poorer. And underlying this is the disproportionate impact that it's had on communities of color. And as I've showed you before, wealth and poverty and community safety, they translate into differential and inequitable health outcomes. I want to talk about racism and discrimination. This is what we're here to talk about. It's not a comfortable topic, but it's an important one. We talk a lot about interpersonal racism. This is a racism that we see that interacts between two individuals. And I want to keep it broad as well. It's not just racism, it's also heterosexism, ableism, sexism as well. But I'm just going to use racism because we've studied it a lot in the area of racism. Interpersonal racism are the attitudes that get translated into the behaviors that people have as they interact with one another. Then there's internalized racism, the things that you don't see, that's just below the surface. These are the attitudes, sometimes conscious, sometimes unconscious, that fuel the interpersonal racism. And then there's institutional racism. Racism that's embedded in the policies and practices of an institution, like the mental health institutions, like UC Davis. I think we're doing great work at UC Davis to be anti-racist and to advance diversity, equity, inclusion. And we're calling out institutional racism as well. But we've got some work to do in this front as well. And then there's structural racism. This is racism that is embedded in the structures of the United States, policies that cut across institutions. These are the laws. These are the executive orders. These are the acts that lead to inequitable care and inequitable practices. And I want to go through each one of these and suggest some ways that we can address these inequities. So let's talk about some strategies. So to address interpersonal racism and discrimination, in mental health, we've actually been working quite a bit. This has been an area since the 1990s where people who've done work in cultural competence have really focused on this area. What can we do to change how providers act with our patients? And there's some good work in this area in mental health. So there's a field called cultural psychiatry that focuses on how diverse cultural groups are treated by a mental health worker. Understanding that mental health workers are socialized in the ways of the dominant culture, which can make us blind to the experiences of people who are not part of the dominant culture. And cultural psychiatry challenges the assumptions of what we consider good clinical practice. And I want to share a tool, make reference to a tool called the Cultural Formulation Interview, which is a tool that cultural psychiatrists have been using for the past, I would say about 8 or so years now. That helps them to center clinical interviews on the person's own narrative of illness, their narrative of their experience, so that we hold that and elevate that as the most important part of this whole story. Of course, healthcare professionals contribute to the story, but the patient or the consumer story is of utmost importance. It also explicitly inquires about the views of the community, of the network of the person in front of us, to better place them in the context of a community. The classic good clinical practice is what we call the therapeutic dyad. There's the therapist or doctor and the patient, and there's a good relationship between the two. But we know from the work in cultural psychiatry that oftentimes the decisions and the understandings aren't established between a doctor or a therapist and their patient or client. It's after the client goes home and checks in with the family members, or has discussions with communities, or consults with elders or faith leaders. And we want to make sure that that is part of the process in the cultural formulation, helps us to make sure that we account for those perspectives as we develop collaboratively steps to move the treatment forward. So there's work being done to address interpersonal discrimination. But I have to say that it's not enough, because in a rush, we may not have the opportunity to do the cultural formulation. We may make snap judgments. And this is where we have to also address internalized racism and discrimination. So we talk a lot in our field about implicit bias. Implicit bias being positive or negative attitudes that a person holds at an unconscious level towards a person, group, or thing. They're part of our evolution. They can be adaptive, but they're irrational, and we all have them, okay? They're based on patterns that we develop over time. But here's the problem. So when we have an inexplicable preference for somebody, for a group, we call this in-group favoritism. We end up doing things for this group and not doing things for groups for members that are not part of what we identify as our in-group. So they've studied this. They've looked at people who are not part of the clique or the in-group, the favored group, and they have been able to show, psychologists and sociologists have been able to show that people who are not part of an in-group get less emotional support. They are given less benefit of the doubt, and they're given less material resources. Everything being equal, everything else being equal. So these biases actually have salience in a person's treatment in society. And you'd think that because it has such a powerful impact that there would be a strong vetting process that people have to bring people into their in-group, but that's not the case. What researchers have found is that your in-group can be based on the length of your hair, the sports team that you like, the kind of clothes that you wear, the region or school that you came from, things that don't really directly link to a person's merit, but determine a person's in-group. You know, we talk a lot about, like in leadership, about, you know, going on the golf course, right? What happens if you don't like golf? You can't make those deals. You're not part of the club. You're part of the out-group. And I think women for a long time have experienced that out-group exclusion, and having to work especially hard to get things done. People in communities of color also experience that. LGBT people also experience that. And it is hard to reverse because it's unconscious. So let me give you an example, okay? I'm gonna share to you that grid A is the same color as grid B, okay? That parallelogram A is the same color as the parallelogram B. You see it? You believe me, right? I'm seeing shaking of heads. Marilyn Moyle, you're shaking your head at me. Okay, I'm gonna prove it to you. Okay? Let's go back. Now you know it, right? Now you see it. Now you know that A and B are the same color, right? Marilyn Moyle, you're still shaking your head. Yeah, that's the power of our unconscious bias, that even though we teach people the appropriate behaviors, they're still thinking about things in a certain way, because the unconscious process can be so powerful that it overpowers our rational thinking. I've shown you rationally that A and B are the same color. I've shown it to you rationally. But still, your knee-jerk reaction is still to see that as different colors, because that's the unconscious processing that's being used. There's an analogous processing for unconscious bias as well. That's why it's not enough just to tell people, hey, if you incorporate a person's lived experience into your interviews, you're gonna do a good job. We also have to deal with the implicit biases. Here's another example. Which face looks kind of off? Most people would say the right side looks a bit more off. However, they're actually the same. And the reason why is that our preferences, we look at people's mouths and eyes to give us a sense of right side up and upside down. Okay, so even though the picture on the left is only 20% of it is right side up, the eyes and the mouth, we still experience it as right, as looking all right. Whereas in the picture on the right, 80% of the picture is right side up, but we still experience that there's something wrong with it. Our implicit biases, okay, are analogous. And so what we have to do is really, we have to recognize that we have these implicit biases, and then recognize when they happen. So when does it happen? It happens when we're uncertain, when we have to make a guess, then we go with our gut. But our gut plays to our implicit biases. It happens when we're overwhelmed. It happens when we're distracted or when we're multitasking. This is when bias happens. So what happens is we have to make sure that when we're in these situations that we think to ourselves, oh, I have to use the cultural formulation because I'm not familiar, or, you know, I have to make sure that I'm slowing down or focusing more because there's a potential for my unconscious biases to result in inequitable care for my client right now. We also then have to look at the context. What causes our implicit biases? Well, it's pattern recognition. It's what we learn by observation. Children see, children do. So controlling what you see on TV, identifying role models that you want to have, and really engaging with those role models so that you can observe. Connecting with communities that you would previously feel uncomfortable with, and finding meaningful relationships. Diversifying the people that help you to make decisions. Considering carefully the news that you get, because they influence your your implicit bias. So addressing institutional racism and discrimination is important as well. And I'm just going to go over this fairly quickly. The DSM-5 is an example of where we need to focus our energies when it comes to mental health. There are, when homosexuality and gender identity disorder was stricken from this manual, it sent a message across all of us who work in mental health that, you know what, there's a change. And so it made us look, why was there a change? And made us adapt new practices. Covered California was a great policy institutional change that allowed for access to health care. This program increased significantly access to insurance. I also want you to be aware of the National Standards for Culturally and Linguistically Appropriate Services, which is a guideline that all institutions engaged in health should be working with, because it gives you a pathway to make sure that the care that you provide is equitable. And it has focus on things like making sure that the leadership is diverse and has training, make sure that your patients are reflected and represented in your provider population, and that there's good language access, and that you're accountable to the communities that you serve, that you provide reports and data that show your progress at caring for the communities of consideration in your area. I'm gonna skip this and focus on structural racism as my final set of slides. So at UC Davis, we've just embarked on the Anchor Institution mission. We can leverage our business practices to be more inclusive, to hire and develop people from the local community and from diverse communities, to engage in business relationships and contracts with local and minority-owned businesses. And by investing our economic capital in communities, we help to build wealth for those community members. Getting people jobs, and we're doing, I think, a very good job when it comes to workforce development for our providers. We're ranked in the top 10th percentile in terms of graduating Latino and Latinx physicians. In recent years, we've been at the top nationally in terms of matriculating Black medical students outside of the HBCUs. So we're making traction in that area, but there's also an opportunity to do it with managers, with IT folks, and anybody else in our university health system. We should be thinking about that as well. We should be thinking about buying locally. And we do that with our Farm to Fork. We're the largest Farm to Fork kitchen in the Sacramento area. And when we invest in the local economy, what we do is we reduce risk that small business has. We thereby reduce costs for other members of the community, and we incentivize long-term investment. So if UC Davis, for example, has a business contract, a 5-year contract with a local minority-owned business, then they're assured that for the next 5 years, they're going to have a steady income. That's going to shift the focus from, making ends meet to, okay, now that I can plan for the next 5 years, what am I doing to develop my employees? What am I doing to develop the infrastructure or contribute back to my community? These kinds of shifts, economists have identified as improving the dollar that gets invested. Every dollar, for example, that gets invested in the local community gives the community an extra 25 to 45 cents. So when we invest in the community, our dollar goes farther than if we invest elsewhere. And this is important because in Sacramento, with Aggie Square, with the expansion of UC Davis Health, there is valid concern about gentrification. Gentrification being not equivalent to development, but it's basically when a neighborhood is developed and the residents of that neighborhood are displaced. They're not able, they're prevented from enjoying the benefits of economic thriving in that neighborhood. And so if we make sure that we do our part to vitalize, support local economies here of color, if we make sure that we develop pathways of job training that lead to jobs in our university and health system, then we help to improve wealth, and we help to share the thriving that we have at the university and make sure that our neighbors as well experience that thriving in addition. It's not easy. The former First Lady said that. Racism is a reality that so many of us grew up learning to just deal with. But if we ever hope to move past it, it can't just be on people of color to deal with. It's up to all of us, Black, white, everyone, no matter how well-meaning we think we might be, to do the honest, uncomfortable work of rooting it out. I want to thank you for your time, and I think we have 15 or so minutes for questions.
Thank you so much, Dr. Tan. So I invite our participants, if you have a question for Dr. Tan, feel free to put that into chat and send it to me. And then I will ask that question to Dr. Tan, and I'll also post it into chat for everyone to see. So we did receive a question during your talk, Dr. Tan. It's a really rich question. So I'm going to put it into chat so everyone can see, and I'm also going to read it aloud. Could you, Dr. Tan, speak to the following? Number one, variables of managed healthcare systems. For example, are providers worried that they will go over time and therefore truncate their time to overcompensate? Number two, lack of cultural humility, potentially leading to barriers in rapport building. And finally, lowered expectations of BIPOC clients related to multi-generational trauma. For example, my needs won't be met no matter what I say or do.
Yes. So, so I'm going to take that in reverse order. So yes, generational trauma, and we're seeing that today. The impact of our lack of attention to developing meaningful relationships and addressing generational trauma and the health outcomes of that with our BIPOC communities. That has led to justifiable mistrust that people have in our health systems. We are seeing that right now with vaccine hesitancy in COVID-19. The whole idea of build it and they will come is not the model. That's a privileged model. That's an ivory tower model. What we need to do is we need to acknowledge the generational trauma. We need to own up to our contributions to it, and we need to work to build that relationship. And part of building that and the reason why we need to do that is that not only for the immediate person in front of us who we like to help and partner with, but it's for communities in the future, because this won't be the only pandemic. This won't be the only healthcare crisis that we will experience. This won't be the only public health crisis that we will experience. And we need to develop that rapport, that partnership, and that trust in order to do well by the communities that have been generationally traumatized. Cultural humility is really essential because, again, cultural humility focuses, pays attention to the power differential between providers and patients. And that contributes to why certain patients are treated less well than others, because providers have the power to make the decisions irregardless of the patient's perspective, or that's in a very patriarchal, paternalistic system. I'd like to say that we are moving away from that with concepts like cultural humility, with tools like cultural formulation that help us to understand the importance of our patients' narratives. And we're training physicians to utilize those kinds of clinical tools that help us to reach cultural humility. I do think that the pressures on clinicians make things worse. As I mentioned in one of my previous slides, when you're crunched for time, when you're feeling overwhelmed, your unconscious biases, your implicit biases are going to play out more. We see that with other kinds of implicit biases that are outside of race and gender, but we see that there as well. And so enabling providers to have more time enables providers to then remind themselves, okay, I scored high on implicit bias in this setting, so I'm going to slow down, I'm going to use the tools, I'm going to make sure that I engage my conscious awareness, even though, because I know that my implicit tendencies will go in a different direction, just as that illusion that I shared with you. At my clinic, so one of the things that we did in the clinic Transcultural Wellness Center was that we recognized that when we use interpreters, it needs to be longer. If it's not longer, there's something wrong. There's a communication problem if it takes a provider less time. And so what we did was we actually carved out 50% more time for providers when they use an interpreter, so that providers weren't stuck with this choice of having to shorten a time with a patient who likely would be less likely to complain because they already felt disempowered from a language standpoint, and choose a patient that was English speaking to spend more time with because of concerns that that patient would be more vocal and advocate for themselves more, which is sort of a natural tendency. We go with the squeaky wheel, right? That's the metaphor. Well, that's a dynamic that happens with people who have limited English proficiency. So yes, managed care can be problematic, but it can also be a source of solutions. So Medi-Cal, for example, has started to implement guidelines for addressing social determinants of health in the practitioner setting. And those things will help health systems to do a better job and providers to do a better job at addressing these factors. This is an example of how institutional discrimination or policies or inequities or attempts at equity can actually help improve or make worse the interpersonal discrimination or equity, promoting interpersonal equity.
Thanks so much. We have a few questions that have been coming in to chat, so I'm going to post the next question that we received. How can we kindly call out our coworkers when we witness such biases with their clients?
Mm-hmm. So I think that this is a great question. There are actually a number of workshops. HR at UC Davis is holding Race Matters workshop. The next one is actually about talking with colleagues and holding them accountable for making these kinds of mistakes. And I call them mistakes. They're oftentimes they're unconscious mistakes that happen, or they're a provider's reaction to a complicated environment where they're feeling pressured. So a couple things that I would recommend. So for yourself, take a pause and develop your strategy. The second thing is what Dr. Chada and I talk about as triangulation. Focus on the problem and build rapport with that provider. Okay, because even some of my providers who I look to for models of cultural humility, I've had to give feedback about cultural insensitivity. And I've also been a recipient of that kind of feedback as well. Because we all contribute to this. And as I said before, there are institutional factors that contribute to our behavior. And so part of it is to then say, hey, you know what? I don't feel like that went well. I feel like the client ended up feeling kind of shut down. I noticed that they started to shut down when we started talking about this, or when I saw you talk about this. What's our goal here? I know that it wasn't your intention to shut them down. Help me to understand what happened and what you were intending. And oftentimes people might say things like, I just didn't know how to deal with that situation. I tried the best I can. I totally fumbled about that. So let's think about how we can address that. Or if you're a supervisor, let's think about how we as a clinic can help you, support you with this. What are some policy factors or things that I can do as a leader to help? What are some things that you'll want to do for yourself? Let's brainstorm together about that. So what you're doing is you're focusing on the problem so that the clinician is not going to be as defensive about that. And you're lifting that clinician up by asking them, what was it that they hoped for? Because most clinicians hope for the best for their patient. No matter, how frustrated they are, they hope for the best for their patient. And sometimes when mistakes like this happen, we lose sight of that. And when that isn't acknowledged, it's hard for a person to change.
Thank you. I want to do a time check. We're at 2:27, so I think we could get through maybe one or two more questions. I apologize in advance. We won't be able to get through all the questions that folks have been asking, and they're really fantastic. I'm going to put into chat a couple of parallel questions that we received. One from a member of the board of directors for NAMI Yolo County, and then another from a practicing physician. And both of these participants were asking, what can a group like NAMI Yolo County, or what can an individual as a practicing physician do to address the issues that you've been talking about today, Dr. Tom?
Well, I just want to give a shout out to NAMI. Y'all are doing great work already in terms of really elevating the voice of consumers and partnering with providers to give that perspective. So for providers, it's really super important. We can't do this ourselves. We have to partner with consumer groups, with family groups, to elevate their perspectives, because those are perspectives that we can't really access otherwise. And that's going to be really important for our accountability. We also want to make sure you should look into the class standards, because both NAMI and the clinics, your provider clinics, there is applicability. There's a guide, there's a map for moving towards a more racially, culturally inclusive organization. So doing that is really important. Look at racial equity tools. When you're making decisions, think about how you're making decisions on a structural level, okay? Majority rules is not going to work for communities of color, okay? And yet it's something that's deeply ingrained in our meritocracy and our democracy. That works in some cases, but when you're trying to uplift disparate care of marginalized people, you want to make sure that the tools that you use to make those decisions are racially equitable. For some examples of that is, are the decision makers, are they able to represent the perspectives of the communities that would be affected by these policy decisions? Number two, have we as an organization projected out the impact that the decision will have on marginalized communities? So those are some things to think about. As an individual provider, make sure that you do take courses on cultural humility, cultural formulation, cultural competence, implicit bias. It's really important that you incorporate that, and then be explicit about that. How are you going to incorporate that into your practice and come up with outcomes that you want to have? Because it's not going to be enough, and we know this from a behavioral standpoint, that if you just go with, I'm going to do this behavior without looking at the outcomes, there are going to be other pressures, institutional structural pressures, that will make you forget about those priorities. And so you need to be accountable. So how am I spending my time with people that whose backgrounds are culturally quite different than I? What kinds of literature am I reading on the history of marginalized communities? Those things are very, very important. Context and history is some of the most important things, because in mental health, we often pride ourselves on taking a good history, but our history are often personal histories. And in psychotherapy, we understand that history goes back generations. We already understand that, but we need to put that into practice when we're taking our histories so that we understand the larger context by which BIPOC people that come to our offices experience suffering, experience joy, and look to the future for hope or despair. That's the historical context that's missing for a lot of providers. And then learn more about racial trauma and intergenerational trauma.
Thank you so much, Dr. Tan. So we're out of time, unfortunately. And as I mentioned, we had a number of other questions, so apologies that we weren't able to get to them. In closing, I want to remind folks that the recording from today is available, it will be made available on the Campus Community Book Project website. On our book project website, you also will be able to find more information about our upcoming programs as well, and we've dropped those links into chat. I also want to give a shout out to you all to our next event, which will be next Tuesday, January 26th at 6:30 p.m. We will be welcoming Dr. Stephen Hinshaw, who is a professor of psychology at UC Berkeley and professor of psychiatry and behavioral sciences at UC San Francisco. Dr. Hinshaw will be giving a virtual talk on stigma and mental illness, the final frontier for human rights. You can find the registration link in chat, and all are welcome at this free event. So on behalf of the book project, I want to thank everyone for joining us today, and thank you, Dr. Tan, for your really insightful presentation. We hope to see you all at a future program.